I'm Nick Niziolomski. I'm the Commercial and Operations Director here at Ortus, and I'm going to be your host today. So we're really excited and grateful for you joining us for this, for what we hope is going to be a very informative and helpful webinar for you. Our theme today is a kind of welcome to the Acuity Pyramid and seeing that pyramid action and looking at the implications of that in redesigning remote care. So tonight we're going to hear directly from NHS consultants, our speakers today, who are delivering safe, scalable remote care at every level of that acuity pyramid, varying from long-term monitoring to virtual wards to hospital at homes. We've seen a lot of change over the last 12 to 18 months. So as virtual wards have become more widely accepted, this session is all about focusing on the how to implement, how to scale, and how to improve outcomes. You'll see real-world pathways, based on real data, and hear about the real challenges. And it'll give us the opportunity to ask questions, take some inspiration, and actually for us all to join together, to join the conversation about what the consequences and what the results of this could mean to our services. In summary, we'll explore the Acuity Pyramid, live and in action. You'll hear from our speakers. The last session will be a Q&A session I'd ask you to, you should see down there somewhere, a Q&A option in this, like a chat button where you can enter your questions. And I'll let you know right now that this session is actually being recorded. And so if you don't wish to be included in that recording, I'd ask you to leave the presentation now. And equally, for allowing us to record it, you'll get access to a replay of it, which will be sent out next week. So let's just briefly now take you through the agenda, and hopefully you're all seeing that. So Dr. Debashish will be opening the presentations today, providing an overview of the Acuity Pyramid in action. He's a consultant cardiologist from Barts Heart Centre, and actually the CEO and founder of Ortus-iHealth. Following on from Debs, you'll be hearing from Dr. Rachel Bastianen, who's a consultant cardiologist from Guy's and St Thomas, and her colleague Ed Burford, who's a cardiology research fellow. Now, they'll be covering the monitoring of patients for inherent cardiac conditions, so long QT syndrome in Rachel's case, and hypertrophic cardiomyopathy from Ed. The final session will be all about pharmacist-led rapid up titration for heart failure patients. And Dr. Chris Primus, a consultant cardiologist at Barts, will be taking you through his experience of delivering service there. We will finally, after that, open the floor up when we'll have all our speakers coming together, and we'll have a Q&A panel where we will take. You have the opportunity to ask your questions, and the questions you've submitted as you work your way through can be raised at that point. So I hope that makes sense to everybody. And that being said, now I will stop sharing, and we'll go straight to Dr. Das, who will present his Acuity Pyramid presentation. Over to you, Debs.
Grant, can everyone see that? Nick, can you see my screen?
Yes, we can.
Perfect. Grant, thanks everyone. Thank you very much. I'll just introduce myself again. I'm Dr. Stasson, the cardiology consultant at Barts. I'm also the founder and creator of the remote monitoring solution that is being used across a number of these pathways. Essentially, I've been trying to deliver remote care for now nearly 8 years, and as you've seen over the last 3 years, then there's been a real big shift towards post-COVID remote care, but really focusing on the term virtual ward. That's really a kind of a terminology that's come in over the last 3 years. And often I've found there's been kind of an interchange between what exactly does that mean, the patient population, and how do I fit that in for certainly my cardiac patients. And over time, I've thought of this as a framework of how I decide what my pathway looks like, how I determine what type of remote care, and what does that mean, both from technology, the staff, what's needed, the frequency of monitoring, and also a framework of how I think kind of the future is going. So essentially the Acuity Pyramid, what I kind of term, is where I see remote care going, of which what are we focused on at the moment, largely in the NHS, is this top of the pyramid. and hospital at home right at the top, delivering acute level care, often requiring more in-person reviews. The middle layer being your virtual wards, essentially requiring hospital level observations, and that can be split between your step up or step down virtual wards. And again, what I've seen across is this interchanging between these two terminologies, but not really quite understanding what type of patient, what can they fit into to both, and where are the real system-wide savings. And the last component, be your long-term remote monitoring, where I really feel is that where the most savings and the preventative care, which will lead to the better outcomes within the health system. And that could be a long-term condition, and we're going to see some of how we use kind of remote care to deliver that into our presentations. But also I want to give an example of how we've done it on an elective care journey, how this proactive approach and remote monitoring can actually reduce the tap into these more medium acuity wards, your medium acuity virtual ward or your hospital at home. So just again, as a summary, your hospital at home, really avoiding hospitalization, providing acute level care, often kind of IV medications, daily hands-on care. Your step down in acuity, your virtual wards, trying to either prevent admission or early facilitated discharge and prevent readmission into hospital. And really managing, key things, managing patients who still require hospital level observation, but safely can be done outside the hospital environment. And I'll give an example of one of the pathways that we're doing. And again, now the kind of the long-term remote monitoring, where it's really focused on proactive care and rethinking some of our outpatient journey. And what are some of the features of it, again, in terms of target population objective? Really, if we focus on the hospital at home, it can really be delivered only in a short episodic care. You know, the cost benefit, I'm still yet to be convinced that there are system-wide cost benefits from any long-term or more within a 2-week span of patients staying at home where we're regularly going to see them. But your mid acuity virtual ward can certainly go into that phrase where we do have those bed releasing savings, and that low touch remote monitoring certainly in our experience has saved costs. And again, technology is really important in this. It is I see it less important in your hospital at home where you're having to physically see them regularly. But in your low-touch virtual and certainly long-term remote monitoring, the ability to remotely monitor, but also have more asynchronous contact with them, releases some of that efficiencies. And again, we will go through one pathway that really accentuates that. So we know that there's a lot of evidence for remote monitoring now, certainly in cardiac patients, where if we do that, we've got colleagues in Liverpool who've shown this in their heart failure population, that beyond your virtual ward 2-week stay, if you proactively remote monitor a heart failure patients for a period beyond their acute admission, you reduce their readmissions into hospital. So with that, what are we trying to do? Improve patient outcomes, the cost savings. And we know from a lot of our remote monitoring pathways that increased level of contact support, there's a high degree of patient satisfaction. So what do you need to deliver that? I'm certainly going to say, given on this pathway, you need a digital offering, certainly for your virtual ward and your long-term remote monitoring, that allows you to seamlessly transition that patient across that acuity pyramid, and integrating that into other tools, PROMs, patient educations, self-management, that really kind of supplements your long-term proactive care. And then, of course, trying to integrate into your electronic medical record. Only with that will it be scalable across your patient population. I go back to my heart failure patient. I really hate the 2-week stay where you give that patient a kit and then take it away from them after 2 weeks, like their heart failure has gone away. That doesn't make any sense to me. So Ortus as a pathway, as a remote monitoring platform, tries to facilitate that. what it allows you to do is build your digital pathway dependent on your condition. Decide, is it a hospital at home? Is it a virtual or long term? Decide the cadence of intervention. What data do you need? Does the patient need devices? Again, a lot of our remote monitoring is completely agnostic of devices. The utilization of asynchronous messaging and then supplementing that with your proms, prems, and health education. That really allows you to deliver an end-to-end complete digital pathway. Remote monitoring is far more than just getting some blood pressure and heart rates back to you. So I just want to be quick because of time. Again, the platform tries to supplement that with patient education on top and your scalable virtual ward dashboards. What I wanted to talk through some of our pathways that we have delivered across Barts and the London region. So our low-risk NSTEMI virtual ward was another virtual ward that we started now 2 years ago. NSTEMIs, as we know, is a significant patient cohort that comes into our acute take. The guidance is to try and deliver angiography within 72 to 96 hours of certainly higher risk patients. What tends to happen is our low risk patients get bundled on in, and so there are often long, certainly significant time spent in hospital while waiting for their procedures. And we are targeted to try and deliver at least 75% of our NSTEMIs within 72 hours of admission. And at Barts, given that we were certainly not meeting that, and that often led to low patient satisfaction and poor patient experience. So what we tried to do was take our low-risk patients based on a certain criteria, low GRACE score, troponin, LV function, and can we take them out into a 2-week virtual ward where we would remotely monitor them, but they would get a date for their angiogram. But so they wait at home, they get daily symptom reviews by an advanced nurse practitioner. If they were deemed deteriorating, they would be brought back into Barts Hospital to try and have their angiogram expedited. But the vast majority actually went on to just have their angiograms as per the date. This slide is a bit old now. We've now done over 1,200 patients, but the percentages are roughly exactly the same. Only about 11% of those, 2.5% of all our Atlas patients had to have their angiogram expedited. The vast majority were stable. I think less than 1% had readmission into an accident and emergency. Just to mention, so that reduced our length of stay for all of our patients, and we were able to increase our compliance with BSIS to 67% now. I think we're now over close to 70% of all our NSTEMIs being treated within 72 hours. And again, the vast proportion of those patients actually had disease. Nearly 50% of those patients went on to have either or some form of revascularization. So in addition, low cancellation rates of these patients. We were changing non-elective patients to elective patients, giving a more predictable list. So not only bed day savings, but now Barts has made over £1.2 million in terms of elective recovery tariff by being able to change a non-elective patient into elective procedure. I'm just going to give one quick last example of a long-term remote monitoring and elective weight monitoring that we are doing pan-London. So that is all the cardiac surgical centres. So we knew post-COVID that there were excess in waiting times for cardiac surgery. We're seeing a shift between significant number of unplanned admissions, and therefore our non-elective to elective ratio was being increased. So what we did was we deployed across London that every single cardiac patient would be remotely monitored across all the centres for deterioration. And again, if they were deteriorating, they would move into either had their treatment brought forward or moved into our kind of low-risk NSTEMI equivalent for a bypass virtual ward, where we bring their their surgical procedure forward, but while remotely monitoring them till we do so. So I just wanted to give some of the so the whole pathway was evaluated by UCL partners, showing significant cost savings compared to the standard of care and remote monitoring. But I wanted to go in depth with some of our Barts data. So between September and December, we remotely monitored over 1,400 patients. 120 actually were deemed to be escalating and had their treatment brought forward. We were able to show a difference between the unplanned admissions in the remote monitoring group versus those who didn't partake in the program, and we used those kind of non-engaged as our control. We saw a mortality difference between the two. So not only preventing unplanned admissions, we were able to show again a mortality benefit in remotely monitoring this kind of high risk group. That's whistle stop. Thank you very much. I'll kind of answer any questions at the end. You're on mute, Nick.
You see, there's always one button I forget to hit. So thank you, Deb. That was a really helpful kind of session. And actually, we had a question from Shalina saying during your presentation, asking about Internet of Things devices to patients, and whether they whether they're using it, is it a virtual ward or a long-term remote monitoring, what's the balance of usage. Shalina will come to that at the end of the Q&A, and we'll answer that question then. So right now it's my pleasure to introduce Rachel Bastianen, who is from GSTT. She's going to talk about long QT syndrome, her long QT syndrome pathway and service, and then she'll be followed on by Ed. So Rachel, thank you, and over to you.
Thanks, Nick. Just to check, first of all, that you can hear me before I start talking. Can you hear me?
Yes, all good.
Brilliant. So thanks to you, thanks to Debs and the team for inviting us to speak about remote monitoring and how we're using it in patients with inherited cardiac conditions. I am going to speak to long QT syndrome, where we are using remote monitoring to improve patient experience and create additional capacity in our overstretched outpatient clinic services. And then I'll hand over to Ed, who's going to speak about hypertrophic cardiomyopathy, where we're using the Ortus platform slightly differently in patients who are starting a new medication for HCM with outflow tract obstruction that requires intensive monitoring and lots of symptoms assessments. So just to set the scene, first of all, for anyone unfamiliar with inherited cardiac disease, and to try and explain why we have capacity challenges. I mean, I think there are capacity challenges everywhere, but in particular for patients with inherited conditions, they require lifelong care. And that means regular clinical review, regular risk assessments, touch points for education and support, and genetic testing. But because this is inherited disease, it's often not just the patient we need to think about, it's also their family. We screen their family members clinically and or with genetic assessment where possible. And with most of the conditions that we're thinking about, there's a 50% risk that first degree relatives will be affected. As a result, and so the combination of the fact that this is lifelong disease, probands are not discharged, and that the fact that screening generates these new referrals, we see growth in our services over time. And this is some data from King's College Hospital, where I'm also involved in the ICC service, which has just shown how year on year we see the number of patients that require our care and input increasing. And obviously that brings with it many challenges. The appointments traditionally for these patients have been at least annual, and that's based on consensus statements with rare disease and in rare conditions like inherited cardiac disease. It's, consensus statements that guide our care, but it's also historically been part of hospital appointment booking systems where it's been difficult to book a patient beyond a year without losing them to follow up. However, most of the people we see are low risk, they're asymptomatic. And that annual face-to-face review that particularly we were tied into pre-COVID is less desirable for those who live a long way away from us. Many do, because we're a tertiary centre. Patients are travelling long distances with the logistics that entails. And many of our patients are young. They've got busy jobs, they've got young families, and taking time away from those is more challenging when you feel well and not in need of seeing a doctor. So is there anything in addition to offering virtual appointments, which have certainly helped in this space post-pandemic, but is there more we can do to see these patients in a different way, helping them and helping us? So this is where remote monitoring has been something we explored. We came across the Ortus platform during the cardiac surgical waiting list prioritisation piece that Debs has already talked to. And what we set out to do was look to see how we might use PIFU, so that's patient-initiated follow-up with remote monitoring pathways, extending that follow-up interval from annually to greater time intervals, but bringing in annual notes review. The Ortus platform lends itself very nicely to that. It allows us to send out annual symptoms assessment questionnaires. It allows us to assess our patients' mental well-being, which can be a significant problem for young people with inherited cardiac conditions, which bring with them, in some instances, risks of sudden death. It allows us to push out education, push out lifestyle advice, send resources to our patients, including some videos that we recorded to help them. What we have worked with the team, the Ortus team, to do was to integrate ECG downloads within the platform. We use the CardioMobile 6-lead devices, which have been validated and shown to be effective and useful for measuring the QT interval and to give accurate QT measurements, which of course is important if you're not going to see a patient frequently, that there's still an opportunity to gather data on how they are doing in a way that encompasses more than just a symptoms assessment. And for long QT syndrome, the QT interval measurement is important. So this is our pathway. There's a lot written on this slide, and I don't want you to even try to read it all. I'm going to walk you through the key points. Our service is led by one of our clinical nurse specialists. We identify patients with long QT syndrome who are importantly low risk and asymptomatic. We onboard them onto the platform face-to-face in the clinic, which we found is helpful in this patient group. There are obviously different ways of onboarding patients, and that is not the only way to do it. But we onboard them onto the platform, we give them a CardioMobile device, and then simultaneously put them onto the PIFU pathway within our own local electronic patient record. We are then able to annually push out symptoms questionnaires, mental wellbeing questionnaires, invite the patient to download their ECG, which comes to us through the Ortus platform. We're able to push out the reminders about lifestyle advice, which is really important actually in this patient group, where there are certain things like avoiding medications and being cautious around tummy bugs, being cautious with competitive exercise, that are important in addition to medication to keep these patients safe. Importantly, we do need to make sure the data that we collect and the assessments that we make through the platform integrate with our electronic patient record, the local one, and that does require a data upload. We can use post or Holter monitors if required, if the patients have symptoms. And at the moment, we're offering the next face-to-face review after 3 years rather than after 1 year, although we hope to push that further to 5 years, to be honest, with this patient group. Of course, if patients become more symptomatic or if their ECGs show any problems, then we want to see those patients and escalate them back into the clinic setting, which we are also able to do and to accommodate. So we the purpose for this was to try and make things better for patients and also better for the service. We've talked about how the patient experience, when you're low risk, you're asymptomatic, traveling long distance is not always ideal. This allows patients to reduce their face-to-face visits. It allows them to send us ECG information from the comfort of their own homes, reducing time off work, reducing travel costs. But it's good for the service too. As we said, the service growth is inevitable, and demand outweighs capacity in our ICC clinics. This means that we are offering fewer face-to-face appointments to patients who are low risk and asymptomatic, and therefore creating additional capacity for those who are high risk or those who have symptoms, and making use of PIFU. The diagnostic side, we were struggling to accommodate Holter monitors because of difficulties with demand outweighing capacity. For patients coming in person, this was also not ideal. If you're traveling long distance for an appointment and then traveling back the following day to return a 24-hour Holter recording, that was really very undesirable. And this pathway also makes use of postal Holters, which mean fewer trips for the patients to the department, and increased capacity for Holters within the department to be used in other spaces. In terms of what we've learned, these are early learnings from a reasonably new pathway. The staffing is, of course, important. Cross-cover of that back end is necessary to make sure that the patients are, their data is monitored, so that escalation can be made if appropriate at any point. Clear ECG traces can take a bit of practice working with the patient, and we now ask our patients to make additional downloads in the first few weeks of going onto the platform to make sure they have that memory for a year down the line. We need to make sure we have notes review slots built into our electronic health record booking system so that the care is joined up between the platforms. We're careful about avoiding digital exclusion and discussing with each patient alternatives. And we continue to monitor the progress within a group. I'm now going to stop talking and hand over to Ed, who's going to talk a little bit about hypertrophic cardiomyopathy. Thank you.
Yeah, we're seeing you.
Okay, I hope everyone can hear me.
Yeah, we're seeing you and we're hearing you. Thanks, Ed.
Okay, brilliant. So just to follow on from Rachel, again, I'm one of the clinical fellows who works at Guy's and St Thomas's Hospital. I've been helping to support a new service that we rolled out beginning of last year, which is for patients with obstructive hypertrophic cardiomyopathy. So just to define the problem very quickly, hypertrophic cardiomyopathy, or thickened heart muscle disease, is a common inherited cardiac condition affecting around 1 in 500 people. Obstructive HCM is a kind of a subclassification of hypertrophic cardiomyopathy where they have the presence of left ventricular outflow tract obstruction. So this is a blockage or a obstruction to the blood as it exits the heart, and usually arises as a result of kind of a combination of hemodynamic and anatomical features. And that the presence of obstruction is associated with worsening symptoms and an increased risk of mortality. Traditionally, treatment for this kind of condition was used kind of non-selective pharmacological agents, things like beta blockers, which were found incidentally to be helpful in this kind of condition, or with invasive strategies, septal reductive therapies, including open heart surgery or alcohol septal ablations. So at the end of 2023, cardiac myosin inhibitors, namely mavacamten, was regulated or approved for regulation in the UK, and we started using this in January of 2024. It's a very effective medication in terms of for symptom control, reduces their left ventricular outflow tract obstruction, and we know it increases their exercise tolerance. But it comes with significant challenges from a pathway or a service point of view. And we know that's because of complications around left ventricular outflow tract obstruction. There's a requirement for pharmacogenetic testing, with which wasn't really established. And there's significant risk for things like drug-drug interactions or fetal toxicity, and a degree of patient education is required. For these kind of patients, we know that the follow-up period is relatively intense. It's quite different to those PIFU pathway patients. These patients, on average, get seen 8 times in a year during the first year of treatment. So it can be quite an invested group that you need to be able to communicate with effectively. So the challenges that we came across, they require this frequent clinical review together with echocardiography. The follow-up period for these patients is variable. It can be anywhere from 4 weeks now up to 6 months. So there needs to be some flexibility and resilience in the pathway that you design. They need to have effective pre-treatment counselling and involvement of kind of a service to be able to give them things like the SIP testing, which is the pharmacogenetic testing, as well as genetic testing, or offer a patient education before they start treatment. And then there's the regulation part of it. It's a high cost drug which goes through several applications in order to be able to deliver to the patient. And then lastly, we needed to have some sort of pathway in terms of patients be able to troubleshoot and for safety reporting when they have symptoms, and a way to assess them in a fast or effective manner. So again, this is quite an involved slide of the pathway, and essentially the journey starts where they have symptomatic left ventricular outflow tract obstruction with HCM, and they go through our local NDT, where all treatment options are discussed. If they're deemed to be for mavacamten, which is this new treatment, they then get entered into this new pathway. And this pathway is kind of heavily reliant on MDT working. As we know, it needs to be robust, but also flexible, and it's kind of evolved over time as guidance or pathways have changed. We developed a one-stop kind of service with a clinical scientist-led visit, where they come in for a single point of contact and have their assessment, including kind of clinical assessment echography in one visit. We involve their CNS or their clinical nurse specialists early in terms of their pre-treatment counselling, but also to give them support throughout the process. And it's got a heavy reliance on integrated pharmacist support, so they need to be able to help us with applications. The dosing regimen is incredibly complex. I think it's a 56-page document when it first came out, and navigating that can be complicated for patient plus or clinician as well. And lastly, more importantly for this talk, is Ortus is our remote monitoring service, and it's integral to the way that we manage these patients and offer them kind of the opportunity to discuss with us if there's problems. So when do we initiate Ortus? Well, it's part of the enrollment processes at pre-screening. So before they even have the medication, they're introduced to the pathway. That includes things like education, so they can read about all the drug literature that may be available, as well as more generally about their condition. And they're introduced to the service at that point. When they come back for their visits, they're offered a patient-reported outcome measure questionnaire, so looking at their symptoms to understand if they're responding or if there's a problem which you may be able to address. And the thing that Ortus has been really helpful with is it gives us this very structured approach to be able to give them symptom assessment scores, so you can design pathways within the system to be able to send those questions out at regular set intervals, as well as kind of ad hoc. It provides that patient information for them to be able to read or educate themselves about what is quite a complex or perhaps anxiety-producing kind of new medication, and then gives them an opportunity to report any symptoms. And importantly, that allows us to act on those things. So there's still the traditional pathways for them to report those kind of symptoms, either through their CNS or whether that be speaking to A&E or their clinicians. But otherwise, this allows them to highlight where there may be problems, and for us to proactively manage those problems before they become an issue. So we can arrange for either more frequent follow-up, we can give them telephone appointments, all those kind of things to react to the symptoms as they develop. And then lastly, we can do that through Ortus itself with kind of clinician-initiated messaging. So we can ask them, a few simple questions to understand whether we need to change what's happening, or if there's any acute issues with things like medication supply, for example. And this is something that we do on a pretty regular basis. Obviously, it's not a 24/7 monitored service at the moment, but it offers them an avenue for those kind of less acute problems for us to be able to deal with. Those PROM outcomes we collect on a regular basis and gives us a good view of how things have developed over time. And that kind of picture at the bottom is a single patient's journey with their medication over time, how their symptoms have changed. And in terms of outcomes from that, we've been able to collect all those PROM data and demonstrate in the real world whether the outcomes that are expected with this medication reflect those which are seen in trial data. And we presented this data at the ACC 25, so early this year in America. And again, we found that using this kind of platform, we can measure things like their outcome measures, which are reportable, and we can see that or track that they are the same as their trial data. Okay. Thank you very much. I'll pass on to the next speaker.
Thank you very much. That was excellent. So we've now heard from Debs about the Acuity Pyramid. We've heard from Rachel and Ed about its use in inherited cardiac conditions. Now we're going to be joined by Chris, who's going to take us through a journey with pharmacist-led rapid up titration pathway. So over to you, Chris. Thanks.
Thanks, Nick. Can you hear me and can you see my screen in presentation mode?
We're hearing you and we're seeing your slides beautifully, sir.
Goodness me, I had a mild panic there as I was doing that, realizing I didn't know how to unmute myself. I don't use Zoom enough. Thanks very much for having me, Debs, and the team at Ortus. It's great to be here. As Nick has said, I'm going to talk to you briefly this evening about what we've done in terms of a structured titration and rapid treatment for heart failure, or a rapid titration service. Me working as a heart failure consultant at St. Barts Hospital and as a clinical lead for heart failure at UCLH, which has allowed us to really blend what we're doing across 2 integrated care services. For those of you who aren't heart failure clinicians on the call, it always amazes my colleagues when I present this information that these are the things that we're asked to do in a heart failure pathway. So the new patient coming in to our services via a 2 or 6 week appointment via breathlessness pathway with an elevated NT-proBNP, or an increasing request in the international literature that we follow patients up at 2 weeks after a heart failure admission, or this third area where we are seeing people on a 6-monthly basis to provide input predominantly for those for heart failure with reduced ejection fraction. Now, I'm expecting that with the next iteration of the NICE guidelines, that may well change a bit, and we will move away, hopefully, from echocardiography on a very frequent basis to free up some of that time for mavacamten usage, and instead use NT-proBNP. There's been a need in terms of workforce strategy to think about which parts of these pathways need to be delivered by consultants and how much is delivered by allied health professionals. And with an increasing group of people who are around because we have drugs that are doing better, that instead of having 50% mortality at 5 years in heart failure with reduced ejection fraction, we are now seeing patients coming back to see us on a regular basis and are able to keep things stable. And we've certainly seen in our services a significant reduction in referral for transplants and also for defibrillator implantation. But of course, that's what we need to do, is get these drugs to maximum tolerated doses as quickly as possible to reassess things at 3 months with an echocardiogram and ECG and think about devices. Now, in the real world, even with utilizing our community heart failure teams, we don't achieve this quickly. STRONG-HF is a clinical trial published in The Lancet showing that versus usual care, if you take a group of individuals who have been an inpatient, are on roughly 50% dose equivalents of all 4 pillars, that they do better with fewer symptoms, improved quality of life. This was safe and well tolerated. It's important to recognize that this happened across COVID-19, and so deaths relating to COVID were excluded. But you see this big difference in mortality with an early separation of the curves at just 90 days. But we don't achieve that. If you think about most hospitals in terms of meeting a 2 and 6 week pathway for new patient referrals, it doesn't happen. Our community services are overwhelmed. We have increasing patients with HEF, and therefore the next appointment across the 5 hospitals involved in what we've done is 2 months in our shortest waiting time. And so realistically, it takes 12 to 18 months to get patients onto drugs in an NHS setting where we've got lots of resource at St. Bartholomew's Hospital. So we thought about a rapid titration service when it came to the heart failure targeted funding round of 23-24. We were lucky that Debs had run a pilot at Whipps Cross that he presented at ESC Heart Failure in 2024 with the whole team involved. And what we did was take that and standardize what we would do for inpatients like STRONG-HF, but also for outpatients for the first time in our local area, have them seen by a heart failure team, and then refer them to a structured titration that would happen rapidly. This would be all supported with Ortus through appointments. They would spend 30 minutes on the phone understanding heart failure with our pharmacist, agree to upload their hemodynamics and weight, as well as fill out symptom questionnaires relating to dizziness, NYHA class, quality of life. And we aimed to have 6 weeks of patient-led titration, meaning that patients would put that information on a daily basis And we were hoping that twice a week, our pharmacist would be able to touch base in order to titrate. And then at the end, a 15-minute phone call with a booked appointment to happen across our 5 hospital sites at 3 months to make a decision about devices. This was ambitious. We started small, but what we quickly realized was that we needed to take advantage of what was possible through Ortus. We were facilitating blood tests at a local hospital. We were using a system called Clio to deliver scripts directly to local pharmacies in order to allow patients easier access. And in order to keep everyone up to date, we weren't creating admin. Our letters were being emailed directly from Ortus out via AccuRx to the GP and uploaded onto the London Care Record. The idea of all of this was to think about key KPIs of safety, quality of life, and patient satisfaction. We were hoping that if everything was up and running, a single pharmacist could deliver 24 new on-boards a week and 36 off-boards a week. We quickly realized that that was going to be tough as we first started. But what we wanted to focus on was mortality and readmissions, improved quality of life, and rapid access to devices for patients. But as a trust, or 2 trusts, or 5 hospitals for us, better outpatient slot utilization, less duplication, an echocardiogram that was being able to make a decision rather than several echocardiograms along a patient journey trying to make a decision about drugs and devices, and of course the financial implications. So since September of 2024, we've onboarded 160 patients and discharged 111, and it has been a phenomenal learning curve, but really enjoyable. Roughly 1/3, 2/3 inpatient versus outpatient across 5 hospital sites, again across 2 hospital trusts and across 2 ICBs. Typical for heart failure, 73% male in their 60s. We have been working hard to make sure we maintain equity across our cohort, so 52% non-white British, the Charleston index indicating moderate comorbidity, and all of our patients sitting in the highest quintile when we're considering index of multiple deprivation calculated based on postcode. We've got better at it. So when we first started and looked at this data in our monthly dashboard, it was taking us 10.5 weeks. We're now down to 8.6 weeks, roughly 6 appointments. And those are touch points delivered via message to increase a dose based on a patient giving us blood pressure, heart rate, and telling us whether they're dizzy or not. The patients have loved it. Our pharmacists are extremely popular when patients come back to see us in clinic. Does it work? Well, actually, the data is phenomenal. Huge reductions in NT-proBNP, which to me are clinically meaningful. And at 3 months, we're obviously behind, but ejection fraction in 51 patients have shown that we are using far less echocardiography when we look at the same period of time over the last 2 years. Average or mean ejection fraction at presentation is 30%, as low as 7%, up to 45% at 3 months. And what that, of course, means is that 50% of our patients have been able to be discharged from a heart failure clinic at 4 months from their diagnosis under a PIFU pathway, which, of course, has led to dramatic reductions in our waiting times. And we've made the decision that 13 patients have needed an ICD much, much faster than we would have otherwise seen. These are the data for ACE, ARNI, beta blocker, MRA, and SGLT2 inhibitors. The lighter color at admission, the darker color at discharge. So 92% on all 4 pillars, 0 readmissions across the last 9 months, compared to 25% across all 5 hospitals. And when we look at dose equivalents, what we're doing is we are achieving this quickly. We are getting people onto huge doses of ARNI. We are allowing them to tolerate MRAs in ways that we do not see in the National Heart Failure Audit. SGLT2 inhibitors are not for all, and for the heart failure clinicians on the call, you will know why I say that. But what's been really interesting is that because of the licensing agreements and SPCs looking at the drugs, by the time we have blood tests to do the potential renal injuring drugs, although we all know they don't actually do that, beta blockers are not required. Their resting heart rates have come down. And so most of our patients are discharged on 5 milligrams or less of bisoprolol. We've saved 659 appointments for those 111 patients and pulled them out of traditional follow-up. Our waiting times are now closer to 2 months, 6 to 8 weeks, rather than 4+ months. And this is having a huge impact environmentally and for patients. They're saving more than 2 hours of travel time. 3.8 tons gets you a round trip across the world, or 2.5 houses in the UK funded for their annual electricity bill. And it's safe. No unplanned admissions. We've had 3 patients started on Localma that they picked up directly from their hospitals, from their local pharmacies. And with 6 admissions, none of them have been related to what we've done. And this was an unintended consequence. Our pharmacists have recognized that overnight, hemodynamics have become very abnormal. Patients have an early way to get in touch. And we've had, therefore, 1 patient admitted with an acute kidney injury that led to a new diagnosis of bowel cancer, a pulmonary embolus, and 4 patients with sepsis who've gone to hospital on instruction from our pharmacist within 12 hours of symptoms. But it isn't for everyone. Not everyone has a smartphone. We're working through one of Debs's MD students on thinking about language and other barriers. You can't rapidly titrate if you've got a Dosset box or a blister pack. And some patients just do not understand the importance of what we're seeing here and have gone back to their local teams in order to follow a more traditional pathway. So I think what we've seen is that we will, over the next 12 months, see a reduction in mortality. We've seen it in readmissions. Patients report improved quality of life via the Minnesota Living with Heart Failure questionnaire. And we are absolutely revolutionizing what we're doing in terms of echocardiography and outpatient slot usage. So from a trust perspective, this has all gone down very, very well. And we are now have our ongoing funding from the North East London ICB, which we're, of course, really excited about. And one of the reasons Debs and I were keen to share all of this with you is we are not trying to make this a Barts health model. I think this really quickly needs to become the standard of care across the United Kingdom, and the SOPs that we have developed and delivered are lift and shift. And so we would be very happy to share this widely. And I want to take an opportunity to just thank the Ortus team, because although there are other tools to deliver this out there, this has been phenomenal. And what we've been able to achieve has been really, really important from a patient perspective. I'm aware of time and we're running late, so I know I've given you a whistle-stop tour, but I thought it important to allow others to ask questions. You're on mute, Nick.
Oh, I've now hit the right button. So thank you. And I've also got the sun coming in. It's summer, but I'm not going to knock it. Thank you for your kind words. So right now, we have a number of questions. We have 6 questions that have come up. So I'd ask all the panelists to turn on their cameras and be ready with their microphones. And the questions are dropping into a couple of different clear kind of areas. Around engagement, around EHR, EHR integration with other systems, and of course about the question around devices. So who would like to? One of the questions is, how did you finalize the from Shalini Gowda asked, how did you finalize on Ortus, and can you explain the benefits? So I'll kind of throw that. I'm kind of working on the assumption that Shalini is looking to understand what it was like to implement and bring your service in. So who would like to answer that question for us, please? Don't be shy.
I'm happy to talk about our experience. So I think perhaps part of the question is also why Ortus. I mean, I think that within London, we had access to Ortus use within, provided through the cardiac networks, and it was already being used and sort of waiting list prioritization, as Deb's talked about, for cardiac surgery as one of the earlier pathways. And through seeing it used there, it got us thinking really about where else remote monitoring would be helpful for our patients throughout cardiovascular services, but obviously as an ICC clinician, closest to home was ICC patients. In terms of how was the setup and the implementation, really incredibly easy. I mean, Nick, Debs, the team, you've made it really easy for us to get up and running very fast on the platform, and therefore for our patients to get up and running very fast on the platform. It's really quite user friendly, even for somebody who's not very tech savvy like me. So perhaps hand over to others to furnish further, but I think it's easy to use even if you're not a tech savvy person.
Thank you, Rachel. we've got a few questions, and we are kind of we're 5 minutes away, so I really appreciate that. Let me just kind of move on to one of the ones. Owen Bebb asked the question: was there a difference with groups who engaged? Were there issues with social deprivation, age, IT literacy? Can anyone kind of reflect on their I obviously have an Ortus opinion on that, but it'd be interesting to hear one of our speakers describing their experience of that.
I'm happy to answer that, Nick, and I think it fits in with what Rachel was describing. So perhaps the Ortus links to the NHS spine. So by what we're talking about is somebody being in clinic, you say, this is going to work, go onto your app store, look for Ortus-iHealth, download it, share your email address. And then by allowing us as the clinicians to invite the patient, it links their Ortus app with their NHS spine. And therefore you pull all of that data down. And we have had patients of all ages, of all technical abilities. And what's been really great is actually what you do is, even for the patients who perhaps are less tech savvy, their families are happy to help, because it's much easier for your family to help you answer a couple of questions on their mobile phone every day, rather than for them to take time off work to travel to come to the hospital all of the time. So that family network has been really helpful. And I think we have to be honest, this isn't for everyone. There are people who will face digital exclusion. But what I think all of us have been able to show is that you remove 80% of your patients from normal follow-up, and the 20% who need some more attention because they're complex, you now have capacity in your service to do that. And I think that makes an absolutely huge difference.
Thanks, Chris. Well, what I would also say there is that we have made a lot of effort to ensure that our app uses a lot of iconography. So to be honest, if they can use a mobile phone, they can actually use Ortus, because they're used to hitting buttons. Whether it's symptoms that are gathered, whether they want to share a photograph of a wound with their clinicians, whether they need to fill out questionnaires, or as you saw with Rachel, if they're using a live call, for instance, to send in their ECGs, that's all been made very, very simple. So we can reach, and we do very effectively reach, a vast kind of arena of people of different skills levels and also languages, etc. Now, one of the other questions, there's a couple of questions that have come in about connectivity to electronic health records. So I'll briefly answer that one. One question asked, Emma Fawkes asked a question about interfacing with EPRs, and Berta Morris asked a question. She said, is Ortus compatible with EHR? And I think it was Epic, but it went in with a G, so EPIG, which I think was kind of, the one describes quite nicely the challenges of trying to bring these dissimilar systems together in the hospitals. Well, we actually, at Ortus, we actually support HR7 and FHIR integration. We've connected to Cerno, we've connected to kind of EMIS, so we are very capable of linking and connecting to the different systems, and certainly Epic is one of the ones that's actually next, if not next, on our kind of on integration roadmap. But a lot of people are deploying Epic now. The critical part typically is the availability of the people in the hospital's teams to be able to support doing the integration. So you can, by adopting Ortus, you have long-term protection, so investment protection, experience protection of using the platform, and can still benefit from the integration when you're able to you're able to get the support internally to do that. Let's have a quick look. We see we've had an explanation already. The benefits. Ortus is compatible with the EHR systems. Another question from Shalina Gowda was about the Internet of Things devices. So she's asked the question about does the Internet of Things devices come under virtual wards or long-term remote monitoring? And from a Ortus perspective, I'd say we have pathways that across all the different acuities that wish to use different devices at different levels from different vendors, and it's compatible. But I think we've actually heard a bit about that today from our speakers. Anybody feel the need to add anything to that, or? Yeah, I just say the other part of this is, again, when you're working with a platform and you get used to the working practices of a platform such as Ortus, what you want to know is that when the technology of new devices, etc., does move on at to some degree of pace, but there's a lag with the evidence base that supports their usage. We are committed to making sure that you have a connected environment, and the devices you choose to use do not hinder our ability and your ability with Ortus to be able to utilize the benefits of new technologies and opportunities like that as and when they arise. I think Internet of Things, I'm just kind of checking through the list. We've also had a question. So Emma, that's your EPR question. Amanda Huddleston has asked a question about thanked you all for your examples and your presentations, and was asking the question about how is funding being secured, and are these processes and are these systems and these intervention support expanding and upscaling out in London and outside of London. So a comment, from an Ortus, from our experience, we've had a lot more interest in long-term conditions and virtual ward monitoring, and I think from an explosion that was made the requirements and the needs quite diverse, it seems to be coming together again based on now experience. So we have a virtual ward that is monitoring, where there's a nurse and a team monitoring 250 patients at any one time, that's sitting in York, supporting a pathway in a London hospital, and is using primarily questionnaires and then symptom collection to be able to support those patients. And then when there's a need for blood pressures or other things, then quite often that patients have those devices, have been instructed to have them from their GPs, etc., all the way through to very technology intensive pathways in the virtual ward scenario. So there's been a much greater growing usage and focus and knowledge about what's wanted now. So we've kind of gone through a bit of a learning session. What I would say is that there's a lot more interest nationally, but when it comes to securing funding, we at Ortus are in our fourth year with the majority of our services in London, so we have quite a long tail with them. Yes, funding is challenging. We're finding, we're meeting now clinicians and services that we're working with to identify and work with them and support them in developing a business case to be able to bring these services on. But it is a challenging time on the funding side. And maybe some of it as a final question, throw that open to our presenters on how is it, how challenging are you finding it right now?
I guess that we have to recognise that the NHS has no money presently, and we are all being asked to do more with less and demonstrate efficiency. I think that what my experience and has certainly been is that if you can redeploy staff you already have to provide additional support, especially for digital remote monitoring, recognizing that most of the people who work with patients like seeing patients. So it's very difficult to get a member of staff who works full time to do everything remotely. And so what I would say from what we have learned is redistribution of staff to share the workload and have experience. And then, we are very happy to share, and I hope we'll publish at some point in some form what we've seen in terms of the benefits, in terms of more efficient use of slots, better impact on echocardiography, PIFU pathways in scenarios where it's unusual to have done that. And those are all cost saving and can be revenue generating. So if you think that every single patient who has been through our service has a new patient tariff associated with it, you've also then improved your follow-up ratios in your consultant-led clinics. So that there's lots of ways, if you sit down with your managers and think through this, to write a very strong and successful business plan once you address that very small outlay in terms of annual cost for the platform itself. I don't know, Rachel, if that's been your experience as well.
I'd agree with that completely, Chris. And, I think that the platform itself doesn't carry a high cost. It's that staffing behind it, isn't it? And getting that right. And I think that there are different ways to look at that. And, one of the models that we're exploring more extensively is how do you perhaps think about bringing together a hub so that you can kind of leverage these economies of scale, and perhaps you can have staff who are covering multiple different pathways and possibly different trusts. Obviously, that requires some joined up thinking and some collaborative working, and cardiac networks are very helpful from that perspective. But I think there are ways to be imaginative, like you say, like Chris has already said, in terms of the efficiencies that this can bring. You can show savings, and that can help to make your business case. And then I think the future perhaps is to think how we work together and leverage these economies of scale across networks as well. But there's certainly lots of scope for growth in this area, isn't there? And I think there has to be for patients and for the NHS.
Thank you very much, Rachel. I think on that very positive kind of message, I'll start to bring the webinar to an end. Let me see if I can just share that. Oh, it's my turn to say, I hope somebody can see that out there. So finally, I'd like to thank everybody who joined us today. And of course, a great thanks go out to our speakers. We've heard today about how how the teams and the pathways you've heard are already redesigning care across the Acuity. And even just then with the kind of acceptance of remote monitoring and a platform like Ortus is, really gathering momentum because of what it does for the patient experience, and also the ability for clinicians to be able to have the information they need as they need it right at hand, and be able to effectively and efficiently communicate with patients, giving them a surety and confidence in the care that they're getting, but also have the decision support to be able to make those decisions quickly and more as efficiently as possible, saving as much time as possible, which means helping more patients as possible. If today's session has sparked ideas for you in your own service, of course, we'd love to carry on the conversation, and we will be sharing this recording in a white paper that will be sent out to you all kind of probably to the beginning or middle of next week. So on behalf of everybody at Ortus and our speakers, thank you, everybody. Let's keep pushing, because here you are at gone 7 o'clock, it's gone 8 o'clock at night, again thinking about your patients and the people we all serve. We're all working together to try and ensure that we can deliver the best possible service. If you want to, you'll have emails as opportunity. You can have emails you can respond to, and we can arrange a meeting, or can facilitate you having conversations with our speakers today. There's just a general email for you to reach out to us there. And what I would say is, once again, thank you to all our great speakers and presenters, and for all of you for listening. Enjoy the rest of your evening, and we look forward to seeing you again in the near future when we know another kind of webinar on one of these kind of key remote monitoring and virtual ward topics. Thanks for your time. Thanks for your cooperation and collaboration, and good night.